So I'm Michelle Feltus. I think you guys probably have seen me before for this. Since we are a small group at the moment, if you guys have any questions or things you want me to address while I'm talking, either take yourself off mute and interrupt or put stuff in the chat. I had a different plan for the session for today, but the speakers had to drop out at the last minute. So this is something that is kind of a little bit more my academic area of interest. And it was something that we weren't really covering in another way during the series. So, education's a giant topic for global EM. We all pretty much like every program will have some element of education in it, whether it's teaching people how to use a triage tool or educating people during disaster preparedness or something like that. There's almost always some type of education involved in a lot of the work we do. But this is more about the research in the medical education area, and that's a little different. We don't do that quite as much. And so, one of my interests when I was like a resident and deciding to do fellowship was I knew I was interested in med ed, but I was also interested in global EM. And so the way I ended up approaching that when I was applying was I applied to programs that would let me do a med ed degree. And so that's actually how I ended up at Stanford, is because they were one of the ones that was happy to have me do a master's in med ed and not do an MPH. And so that's kind of like where this started. When I started fellowship and started my master's, one of the things that I kind of had to learn was the difference between just med ed in general, kind of like the actual teaching part of education, so like the practical part of it. So that was like part of what I was learning. But then I was also learning that is actually distinct from the program evaluation or the research in it. And so that's part of what I'm going to be talking about a little bit. So I'm going to kind of cover some of the key concepts of this about curriculum design and research design, and then some practical challenges to it when it comes to this. So, as I mentioned, a lot of global EM includes MedEd. Some of that's like very clear in things like residency program development, med student teaching, faculty development, teaching GPs, the basics of emergency care, the BEC course, like courses for EMTs or community health workers. A lot of that is founded in MedEd. But then you also have any type you have a time you have a new system innovation, you also usually have to teach people how to use it or how to implement it. And so there's often an education component in that part as well. But when it comes to publishing, even though this is a huge part of what a lot of global EM programs do, there's not nearly as much published about MedEd in global EM. There's some, especially on things like train the trainer, there's some about like the BEC course, like things like that. But there's not as much about like the actual implementation, like how you do the research or how you actually implement the program and evaluate the program well. And so I'm going to kind of frame this around a very simple project I did in fellowship. So this was a train the trainer program that we did in Rwanda. And so I'm going to come back to this after kind of talking about this and kind of describe like how a lot of this fits in there into this particular program. And then if we have time, I can also talk more if people want about more current. So part of the reason I did the master's was because I had figured out as a resident from talking to my mentors that did education work that there's a lot more specialized lingo. And this isn't really surprising. I feel like every subspecialty area has its own language, its own way of describing things. And so part of what I wanted from the med ed masters was to understand that lingo so that I could then apply it to global EM. One of kind of the bigger parts of this is that the med ed lingo has a differentiation between assessments and evaluations. Assessments are focused on individual learners. So when you're giving a resident feedback real time, that's assessment data. When you're filling out like a resident, even though we call it a resident evaluation form, that's truly assessment data because it's focused on the individual learner. So things like in-service scores, pre-test, post-test, like that individual data is assessments. When you look at it as a whole and start gathering additional data about the program, that's when it becomes an evaluation. And so those are programmatic level. So program evaluations are defined as the systematic collection and analysis of information related to the design, implementation, and outcomes of a programs for the purposes of monitoring and improving the quality and effectiveness. That's basically, it's really kind of all of what we think about when we're looking at evaluating a program. We want to know, did it work? Was it useful? And how can we improve it? And so you have to look at the design of it, you have to look at the implementation of it, and you have to look at the outcomes of it, essentially. This leads into a bunch of conceptual frameworks, and there are a ton in the MedEd literature. I'm only going to highlight like a couple of them, but I have a couple of articles at the end that are useful in kind of describing the different frameworks and the different design theories for MedEd programs. And so there's a lot of learning theory about how adults learn. The book cover here, How Learning Works, is one of my favorite ones from my master's. And it's essentially kind of the basic principles of teaching adults. So, like, it has to be learner centered because an adult usually isn't going to pay attention to you if you're talking about stuff that doesn't matter to them. They have better things to do. They're just going to space out and start like thinking about like their to-do list for the rest of the day. So specific things like that. That How Learning Works book kind of summarizes a lot of different components of different learning theories, which is kind of why I like it because it's not really focusing on any one thing. One of my favorite learning theories is cognitive learning theory. This is the idea that learning is internal. So when you're teaching somebody, they have to internalize the information and kind of make their own network of that information. So when I think about this as a med student, for instance, the first time they are doing pathophys or even just basic physiology, they will learn the heart in isolation from other systems because they don't know the other systems yet. And so they'll have a few things when they're thinking about the heart, they'll think about things like stroke volume and cardiac output and blood pressure and things like that. But they won't have the depth of knowledge to be able to connect that to how the lungs fit into this or how the kidneys also fit into blood pressure management, things like that. As they get more information and become more expert, they get more connections in their mind about how those things fit together. And you need to have those kind of higher level connections in order to become expert enough to understand complex situations. So thinking about something like pulmonary hypertension in isolation only to the heart doesn't really make sense. Like it does affect the heart, but it's also affecting all these other organs as well. And so you kind of need to have that expertise in order to get that together. That's cognitive learning theory, is that you have to be able to kind of make connections between different areas in order to show that expertise. One of the reasons I like this idea is that it's very intuitive to me. That's something that I feel like we can kind of see that happening real time with learners as they're progressing, is they kind of figure out how to connect one concept to another in order to incorporate it, especially early on in training. That gets a little harder when people are more expert. So when you're focusing on a single skill, so like teaching ultrasound, for instance, it's you're trying to figure out how you're trying to teach them how to like integrate ultrasound into their already formed schema. So like how to use an ultrasound in order to evaluate the heart and the lungs and fluid status and all of that. So you're trying to like embed that. That works for things that are like very basic for like significant knowledge acquisition. When we're thinking about things that people are learning, they're also learning skills, that'd be like how to use an ultrasound, but you're also often thinking about attitudes. So and some of that is going to be like developing your identity as an emergency care person, somebody who's comfortable managing acute care. So then you start adding in other theories about how the learner is going to incorporate that knowledge, whether they're going to kind of embed it into their own way of thinking. And so then you get things like the humanist theory, where this is something where the learner needs to be self-motivated. They need to actually want that information in order to incorporate that information and learn the information and remember it long term, is it has to be something that they want, that they want to do. So people that are doing a course for just the certificate at the end and have no intention of using it are not really going to get much out of that learning based on the humanist theory. And so when you're planning something using the humanist theory, you may spend more time at the beginning identifying what the learner wants and what the learner actually needs to use out of it. These are things that you're already thinking about doing. You're already going to be thinking about doing a needs assessment before you start doing a project. But in the med ed literature, these learning theories are how you would describe it. And it sounds a lot more complicated than it actually is with this. There's system theories for things like curriculum development. I'll talk about two of the biggest ones. And then there's also theories about how you evaluate or how you design studies. This is a lot more than I can cover in this morning. So I'm just going to kind of give some highlights to it for some of these additional theories. So for the systems theories, the one of the most common is Kern's model of curriculum development. They're now on the fourth edition, and so Kern is now listed as the second editor, but Kern was like basically the person that wrote the initial book of it, that kind of developed the initial idea. And so with this, it's basically how you would design a curricular program. And it sounds the kind of steps of it are actually very similar to a lot of other research. You start with problem identification. So, kind of like looking at the big picture, what are you trying to do? So, that can be something as simple as being like, this is where we are right now, and this is where we want to be. So, it could be, I've been asked to go to a new site and design an EM curriculum for the medical students when they've never had an EM curriculum. So you want your big pictures, you just need the medical students need some kind of education in EM. Then you go in and do the targeted needs assessment. So that's looking at specifically what the learners are. So where are they in their training? Are they preclinical? Are they clinical? What kinds of experiences have they had before? Have they done surgery, but not internal medicine, et cetera? Kind of what exactly they need. An additional part of this is that you also want to look at what the specific sites you're working with and what the specific partners. So for something like this example, the idea of teaching and developing a med student curriculum for EM in a global setting, it may be what are the med students going to be doing initially after graduation? Is it a country where everybody does a GP year and most of them work in accident and emergency kind of like wards kind of thing at some point? So they need to have some understanding of how to approach a sick person, a completely undifferentiated sick person. Is it something where they're all going to do subspecialty training? And so they more need to understand like how to fit in to the ED, which would be more of like the style of how it would work for the US kind of thing, where they need to understand like how the ED functions in order to properly do a consult, for instance, within it. You're also going to be looking at like at the learning environment. So what are the actual tools? Are you going to be doing this mostly over Zoom? Are you going to be doing this in person? Are you going to have access to a sim room? And kind of what are the things that you can use in order to develop your curriculum? And then you could take all of that assessment information and develop the goals and objectives. So the goals are usually more on the program level. So what does the institution want? What are they wanting to get out of your program? And then you're also going to be looking at the learner-centered objectives. So looking at things that meet the SMART criteria. So specific, measurable, like all of that kind of thing, the timely, all of that. So that you can actually develop something that you can assess and that will have a impact in the amount of time that you have to develop it, to implement the program. Then once you go through like your objectives, that's when you end up making your educational strategies. So that's designing so that you end up designing the content to meet those specific objectives. So essentially you're not wasting time on something that is not meeting your objective, that doesn't actually do anything to meet your objectives. So for instance, teaching about LVADs in a country that doesn't have LVADs at all. It's kind of like a waste of everybody's time and would not be a higher level objective in a program that you're kind of developing. Like you want to make sure that you're actually meeting the needs and not spending extraneous time on things that you don't actually need to cover. This is also when you develop the methods. So, how you're teaching different things. So, some things are better taught in lecture format. Some things you're going to want to design as assigned reading for like a flipped classroom kind of model. You can also have things that are in the like what's going to be small group or simulation or discussion, things like that, or skill sessions. Then once you have your strategy, that's when you actually do the implementation. And so that's one of the key parts of this that is huge for global EM is the political support, kind of figuring out like how to navigate the problems that come up during implementation. So, like how to find the room for teaching, finding, getting there, making sure you have enough resources, making sure you have the right equipment, and kind of coordinating the supplies that you need to do that teaching. All of that will come under the implementation. There is often a lot of lessons learned in this implementation section that can sometimes be its own paper. You can have your own lessons learned paper about this in order to like to kind of talk about the barriers that you're overcoming. There's also a lot of flexibility required. This is definitely true. Global EM is true of MedEd in general, where you often will need to adjust based on the fact that today the projector's not working or the person that was supposed to teach got sick, etc. All of that kind of comes under the implementation section. And then you get to the evaluation and feedback. And so that's when people are doing things like filling out surveys. You do want to make sure that for this evaluation and feedback component that you are looking at all participants in the program. So that includes the learners, of course, but it's also including the people that taught. So they may say this style of teaching didn't really work. You wanted me to do a lecture on something that really I think would be better, time would be better spent on a skill session with it or a small group simulation type session so that you can get feedback from all of the people. That also sometimes might include coordinators, so people on site that are helping you set stuff up. They may say like, "Hey, we were able to get this equipment this time, but it's never going to happen again." Or this part is just too expensive. We won't be able to do this. Method will not work in the future. So that you can kind of make sure that you figure out all parts of getting feedback on all parts of your program. This is kind of the higher level, like curricular design idea. So this is the conceptual framework that gets used by most people for any kind of program design. I think it's pretty similar in terms of like a lot of the steps of most research studies as well, in that it starts with a needs assessment and then you figure out like what exactly you need to do, what your specific goals and objectives. And so in clinical research, that'd be what's your clinical question, and then what's your research design. So it does map decently well to other research kind of theory with us. So the next program design model that I'm going to talk about is a logic model. So this comes up a lot in kind of implementation science. It comes up in kind of clinops research, things like that, where people are looking at kind of a more often more linear idea. One of the nice aspects of the logic model is it can actually clarify, you can use it to clarify who all the stakeholders are, because you need to be looking at everybody for the inputs. You need to figure out exactly like what you're trying to address, what you're starting with, and like who all the people that you need to address are for the inputs. And then you're going to be looking at the activities, so what you're actually doing, and then the outputs, so kind of what you're trying to get done, and then the measurable outcomes. When it comes to MedEd, I find looking at this as an example of a logic model for a curricular program is helpful. Where you're looking for the inputs, you're looking at kind of what's available, like what resources are available. But ahead of that, you're also thinking about what the situation is and what the different priorities are. And so that can help you address things like politics or things that'll be helpful in order to get funding or buy-in from the different stakeholders. So one stakeholder may be able to get more funding for a program if you're able to tie it to a specific topic. So something like a maternal child health initiative, or if it's something that specifically aligns with the mission statement of the institution that they're working in, they may be able to get better buy-in if you phrased it in that way. It kind of helps looking at all the different stakeholder engagement for this. Then you're looking at the outputs, which would be kind of like the specific activities. So it'd be like for education programs, it's going to be things like a workshop or a simulation session. providing different resources, so access to a question bank or literature bank for people. And then you're looking also at the participants at this point as well. It is helpful when you're developing a logic model like this to also think about, like, kind of specify the assumptions that you're making. So something like the topic is important for everybody, that may or may not be true. So you may need to highlight, this is my assumption that I think that should be taught to all medical students, for instance. I feel like that's not a controversial statement when you're talking to EM physicians. When you are talking to people outside EM, they may be like, why specifically do all physicians after training need to have some understanding of what emergency medicine looks like? So that may be something that is helpful to identify early on so that you can phrase it like that. So you can bring that up when you're talking to stakeholders that are outside your initial like consulting group, like your initial group thinking about the project. You're also going to be looking at using this to look at the outcomes. And so that can be one of the nice things I like about this one is you're looking also at the short term and the long term. So the short term is going to be immediate knowledge acquisition, for instance. But long term could be patient care impacts for something like ultrasound usage over time if you did an ultrasound curriculum, for instance. For something like a MedEd kind of teaching session for medical students on emergency medicine, what it is. It could be kind of going back in a year or two and kind of making sure that they still have an understanding and still have the framework of how to approach a sick patient with the ABCs, for instance, something along those lines, something that's going to be about their behavior or practice in the long term. And then super long term, it's going to be what's the ultimate impact. So if you could get data from that med student cohort 5 years down the road and see, like, do people that had that med student training in emergency medicine, like basic principles, are they having better outcomes when they're working as a GP in the A&E wards and their district hospital, for instance? That would be kind of like ideal long-term impact data. It's also one of these logic models can also be used to kind of identify all the external factors for this. This is something that the first time I saw one of these, it seemed like a lot of time to put in upfront on this. But it is something when, if you have a project, especially one that's big, like kind of wide ranging, that it's not just education, it's also looking at patient outcomes or it's kind of education within a larger thing. So triage protocol, implementation, something like that. Having this kind of logic model can be really helpful to kind of make sure you're kind of keeping all the different pieces in mind throughout the project. It's also very helpful when you're taking an idea for publication or dissemination. So something like a logic model, something like this is really nice to be able to put in an abstract, like poster presentation. It's also could be really nice to have as a planned figure for your paper for this as well. Then I wanted to talk about the Kirkpatrick levels. This is probably one of the most commonly used evaluation designs, like evaluation frameworks out there. It's not necessarily the most thorough, but it's probably the one that is the most widely known. And it's very focused on the learner outcomes with this. So it starts at level one, which is kind of reaction data. So did participants like it? And so this still also includes all participants. So faculty, teachers, the administration of whatever institution you're working with, what did they think about it? What did all the individual people think about it? Then it's how much did they learn and focusing on knowledge, skills, and attitudes. Some of it could be, do they feel comfortable approaching a sick patient at this point? Do they have an idea of where to start so that they don't freeze when presented with somebody sick? Behavior level data is looking at how participants actually apply it. So did they actually change what they were doing? So in a med student curriculum where you're teaching EM, it could be looking at a sim, not so much a sim, but like kind of watching them as GPs when they're out working in an A&E and seeing how do they do, like when they are getting a sick patient. Do they start with the ABCs and kind of make sure to start with the stabilization of the patient first, or do they go ahead and do they start doing a history and taking a long time before putting the patient on oxygen, for instance? Like kind of, are they actually changing the behavior that you want them to change with that? Then we get into the absolute gold standard, which is the results. This is really more in MedEd. It's really patient oriented. It's kind of systems level. So absolute gold standard is going to be like, how are patients doing? So you implement an EM residency in a site, and what is the morbidity and mortality in the emergency department 5 years later, for instance. That would be amazing MedEd data. That is also incredibly hard to get. The higher you get on these levels, the more confounding variables you end up having. So it gets harder and harder to kind of figure out if your intervention, your educational program was truly the reason for the change. It's also just much harder to get the access to the data. So even in systems where we're working with electronic medical records, it is really hard to get data on what patients, specific patients are doing, and have that be able to be tied back to a specific intervention is incredibly hard. One like idea of that in kind of US would be, say actually this would apply for global EM too, say you taught a procedure skill, like a sim lab on doing a nerve block for hip fractures. Then outcome data, the patient level outcome data would be how many of your learners actually did that on a patient, and how did the patients do? Did they have a decrease in pain scores, for instance? So you have a very clear intervention at that point, and then you need to follow the data for a certain amount of time to see whether it was actually used. Like, how many of your learners actually did that nerve? The limitation of Kirkpatrick is really that it's focusing a lot on the individual, a lot on the learner. So when it comes to an evaluation, it's not really thinking about kind of the design of the program at all. So it's really looking just at the learner outcomes. It's not necessarily looking at kind of bigger picture stuff. So kind of bringing that back to the med ed research, the steps of the research are still very similar. They still kind of map into something like the curricular design for this, but it includes a step to identify the framework for your designer evaluation. So you still have to think of the purpose, like, why are you doing the evaluation? So that's kind of step one. Is it program improvement, truly just quality improvement? You want to know like how to fix this. You know you're going to have to keep implementing it, and so you want to make it better. Or is it more, hey, I don't know if this is worth our time? Is it worth taking time out of the schedule to add these teaching sessions? Or was it kind of just people just thought it was a waste of time, or not worth the amount of effort needed for it? Then you would take the conceptual framework for it. So you think about things like the Kirkpatrick levels. It is very rare, I think, to see MedEd, like most MedEd papers are going to have some mention of a Kirkpatrick level, like what kind of assessment they're doing. But you also are going to be thinking about different designs. I think the most common one that I've seen and have used would be something like the time series experimental design. And essentially, you're just looking at the behavior of a group or person over time. So you have a pre-program kind of knowledge assessment, for instance, and then you have your curricular program implementation event time, and then you end up having after the implementation. So that would be a time series experimental study design for this. That's I think, like I said, the most common for what we do in Global EM. Ideally, you get pre-data and then you get post-data after, even if it's just immediately before and after your project. Then you look at what outcomes are going to be measured, and then you figure out how to measure those outcomes. With MedEd research, there's a lot more opportunity for qualitative study designs. So free text responses on a survey, for instance, would count as qualitative research because it's something that you have to map. You may also have some quantitative data for things like test scores. This is also a good time to think about your stats plan. And I have found that most of at least of my work, you don't have very many participants. So I've had like ultrasound courses that I've taught that have had 5 people because that was the class of residents for that site. There is no way you're going to have a statistical difference. It's going to be incredibly hard to get a p-value under 0.05 for this kind of thing. So you often are going to be doing things like, what's the confidence interval? For instance, you're going to be looking at like kind of a different stats plan. There is a really good paper on statistics for MedEd that kind of takes through like, this is what you're looking at, and then helps you figure out what kind of statistics plan you can use based on that. Stats is not my strength at all. This is one of the papers that I look at and then go talk to people that are more statsy than I am at that point. Once you get kind of your plan made, that's when you conduct your evaluation and then you disseminate the results to stakeholders. So the dissemination is one of the parts that I don't think we do all that well in global EM. I think that's something that there's definitely a gap in the literature that we can fill with this. One of the biggest things is that you really, in an ideal world, you do want to consider program evaluation during your planning phase of your project, of your program, mainly because it does require time. If you want to do a pre-test and a post-test, like a written exam, for instance, you have to build that time into the schedule. So you have to have some planning for that. Additionally, IRBs take time. So if you're planning to publish at the beginning, like you start a project and you know you're going to publish it, ideally you would do the IRB before you implement your project, of course. And it always takes more time to do an IRB than you think. Most MedEd projects are considered exempt because there's not really any risk to the learner. It's something where they're going to get the teaching regardless. And if you have anonymized data, there's really not a lot of risk to the learner for providing feedback about that project or about their experience of that teaching session, for instance. You also may want to plan for follow-up evaluations, determine kind of persistence of knowledge, or evaluate future changes in behavior. This can add time and can require more money. So if you can plan for it ahead of time, it'll kind of make things smoother for everybody. So you can tell that there's definitely going to be an ideal version of MedEd research and then the reality of like how most people actually do it. So like I said, in the ideal world, you plan for evaluation at the beginning. This may be super short. It may just be pre-test, post-test kind of thing. It may be planning for time for people to take a survey at the end of your session. And it includes like the IRB as part of it. The reality is that program evaluation is often an afterthought. I don't know about anybody else, but most of the time when I'm working with a partner, they often don't need that evaluation data. They know they need the teaching and they need that knowledge or skill session or whatever it may be. They need that, but they don't really need to justify the existence of the project because it's something that it's like such an unmet need that they don't need to say like, hey, we did something and it worked. They just need to say like, hey, we got it done finally. Like, we're able to do this. There's also just a lot of barriers to the ideal implementation. It's often time. For me, that's often the biggest factor that does connect to money or resources as well, because it costs more money to be abroad for a longer time, for instance. Like if you have to do an extra day in order to build in enough time to get a pre-test and a post-test and a skills assessment before and after you do something, that does require more money. And there's also a lot of other barriers in terms of kind of navigating the IRB as well, like especially places that have kind of newer systems, they may not have encountered MedEd as much. And so they may not be used to thinking of things that really are truly exempt. They may not have a pathway to identify things as exempt. And so something where one institution may say you're exempt, you don't really have to fill out anything else. You just do like a quick form and that's it. And another place may actually have you do a full IRB submission. So that means that a lot of the times we end up going back and getting IRB approval after the fact. We do data collection for quality improvement only, and then go back and get the IRB approval later. That's something that is not ideal because it means that you don't really have a lot of way to change things like the consent process. If you want you to have a formal consent form or something like that, you may have to go back after the fact and get consent for people, which then gets complicated if you have anonymized data and somebody doesn't consent. How do you get rid of that one person's individual's data when you don't have a way to link it to them? Things get complicated when it comes to that. I haven't had that come up as a problem. All of mine have been kind of just after the fact, kind of been like, oh yeah, that's fine, go ahead, we're approved for this. But that is something to think about, especially if you're getting more qualitative data. That tends to be where it gets a little harder to keep things anonymized, potentially. One of the bigger challenges is making sure you're actually meeting the true needs of your learners and participants. Are you getting them the actual information that they need? Did it achieve the goal that your partner actually wanted for this? Are you getting the evaluation data that they may need in order to get additional funding for future years? So that is one of the challenges. If your partner doesn't really care about the evaluation component, where they're like, yeah, just basic low level reaction data is plenty for my institution, then that's a lot easier. But if your partner is like, hey, it'd be nice to be able to show that ultrasound has an impact on patient care, because then I can go to the Ministry of Health and argue to get more ultrasound probes in emergency departments in district hospitals that are staffed by emergency trained physicians, for instance. That is a much more complicated need to meet. There's also cultural competency considerations. So, not just in terms of how you're teaching and making sure you're using culturally appropriate like scenarios and teaching sessions, et cetera, but it's also when you're evaluating things, it may take time to get participants to be comfortable giving feedback, to be comfortable with anonymized responses. Sometimes language barriers can be surprising. I've had this come up with Likert scales before, where they were just generally used to having one be strongly agree and five be strongly disagree, or vice versa. And it was something where knowing that ahead of time would make your evaluation process much easier. So you don't get one person saying they thought like it was an awful program on paper, but when you talk to everybody, they're all like, no, it was great. And I don't know if this is a problem with people interpreting the form or not. Kind of just like a who knows kind of thing. IRBs themselves can be complicated because you often will need multiple institutions, because you will need your home institution and then you may need the local institution where you're working as well. And as I said, people that don't have experience with MedEd research often get confused. Right. It's something where they often don't really understand the outcomes that you're looking at. Then it's access to the data itself can be just very complicated in global EM. And when you're using paper charts, it's going to be incredibly hard to get Kirkpatrick level 4 data on patient outcomes, unless it's something like a very large single time intervention, like implementing a global EM residency, where you can get pre-implementation mortality data and post-implementation mortality data, where it's a kind of just very big picture. It can be really challenging to get that kind of data. Qualitative studies are a lot more challenging to implement because you may need people that speak a different language. You may need to find research assistants to be able to do that for you. You may have the language barriers to it. And then it's just timing. It can be difficult to go back and do a follow-up assessment just because that does require an additional trick, for instance. So you may want to be able to show long-term knowledge acquisition, but from a logistics standpoint, being able to go back and do another skills assessment to show that they still remember how to do something can be very expensive. And then there's kind of a more existential problem where MedEd research is often discounted when it comes to clinical research. We get this also with global EM. So you kind of get it potentially on two fronts when you're doing global EM MedEd research, where people at your home institution may just be kind of very confused as to what you're doing and why it's important. And so it's helpful to have partners in your home institution that also do MedEd. So if you have a MedEd fellowship, for instance, at your site, or people that are doing research in MedEd, they can be incredibly helpful to kind of overcome some of the lingo barriers, as well as kind of join together in order to kind of help get your system to be able to work well with MedEd research for this. A little bit about dissemination. There's the usual globally journals, so annals and WestGem and all of those. But a lot of journals for kind of MedEd overall may have an international supplements or still be open to internet publishing work on global education initiatives. So, for instance, the project I did with Train the Trainers in Rwanda, that I published in the Journal of Graduate Medical Education's International Supplement. They had a call for submissions. Same thing will happen with ultrasound. So if you're doing an ultrasound program, if you're doing a novel curriculum intervention, that's also possible. Additionally, you can also look at for open access, BMC MedEd and MedEd Portal are both free open access sites. One of the cool things about MedEd Portal is it also is a place to publish, both find and publish innovations in kind of curriculum. So that could be a lo-fi, low fidelity simulator model where you're able to teach how to do chest tubes or something like that in a low resource setting without having the formal chest tube trainers that we have. And then you basically, so it is helpful if you are doing work in med ed to be on these different kind of newsletters or different like kind of email lists for these different institutions because you might find, oh, hey, they're actually asking for an ultrasound thing. And I know somebody who is working in ultrasound. This may be a perfect time for them to submit, perfect place to submit their paper on this topic, for instance. For conferences, for abstracts and for abstract submissions, there's the usual global EM groups, like all of them do MedEd publications all the time. But you can also look at AMI and ICRE. So AMI is the International Association of Health Profession Education. One of the nice things about them, I still haven't been to this conference, but it's almost always in a beautiful place in Europe. So I think the next coming up one is in Barcelona. So it's a great way to get a cool trip for an interesting conference. They definitely do a lot of med ed research. And it is something that, like I said, I haven't submitted there, but I have heard from my colleagues that do US med ed work that a well-designed abstract that kind of meets all the criteria that I talked about is able to talk about a conceptual framework in the design and things like that is definitely possible to get accepted, both AMI and ICRE. ICRE is the International Conference in Residency Education. So if you're doing kind of EM residency development or a project for them for international residency in an LMIC, you could definitely think about submitting to ICRE as well. CORD and AAMC really are very focused on the US trainees. So if you have something that does overlap with US trainees, this will work. So for instance, one idea would be something like a bidirectional partnership for residency learning, where you have your US residents go to your partner site in an LMIC and then bring some of the residents from your partner site to visit you. Doing an evaluation of that could definitely be an interesting topic for both CORD. AMC would be if it was involving more students. And then you also might want to look at regional conferences. So for instance, I did my master's at USC and they have an Innovations in MedEd conference that is relatively low hanging. It's not as competitive to get something submitted and it does count as a regional or more technically national conference since it does look at people from across the US. So kind of, you can also look and see in your local areas, institutions may have a MedEd master's program and see if they have a regional conference associated with that, like a smaller conference associated with them. But for instance, looking at this APLS course that I did in Rwanda, it was a train the trainer for APLS, so pediatric life support. It was for EM crit care, anesthesia, and peds residents in Rwanda. We did the first cohort was more senior residents, and then the second cohort had more junior residents, who were taught by the first cohort plus the initial faculty group. So it was truly just train the trainer. But we added in a how to teach sessions for the first cohort. So that was like general teaching tips, how to do a simulation or a small group, how to do specific things on procedural like skills training, since it's a big part of APLS, and then how to give feedback. And I'll say the residents that were part of this were incredibly engaged, especially with the feedback section. We then did some surveys as part of our QI plan, and then after the fact submitted the IRB. It was considered exempt at Stanford, but that was like months after the fact. And then we were able to get it published in the Journal of Graduate Medical Education as a 2 or 3 page at most article. Like it was very short, very basic kind of thing. It's like a very simple project that I think gets done a lot, but putting it in this kind of framework, purpose of the evaluation was to figure out if it was useful to include this kind of time. It was supposed to be 2 hours of teaching time spent on learning how to teach. It ended up being closer to 3 because the participants were super engaged and kept asking questions. It's a lot harder to shut people down when they're like, how do I give feedback in a nice way kind of thing? So That was really like the point of this. For the conceptual framework, it was really, we just looked at Kirkpatrick level data, like it was reaction and learning. We didn't have anything where we went back for looking at it in the future. We didn't have teaching assessments, anything like that. We did have some Kirkpatrick data, some survey data for how the learners felt about having their colleagues as the teachers. That was kind of one of an additional outcome. We also asked the trainers, like how they felt as a teacher before and after the course. So we had to figure out how to measure the outcomes. Like I said, it was more survey data. And then we just included the evaluation in the surveys as part of this and then disseminated. So that was kind of like how this very simple project would fit into this like MedEd research plan. We're kind of at the time where the fellows can also just chat with each other, but just one word on grant funding. It is very tough to get funding on MedEd. A lot of the EM education grants focus on US trainees. So it is a little tougher. It is worth an email if the call for proposals isn't clear. Like if it doesn't specify something about US or Canadian trainees for domestics, you can go back. You can send an email to be like, hey, like I have an international project. Would that meet your criteria for this? But you can also look at SAM grants. So our MedEd specifically has a grant only for our MedEd graduates. I'll talk about that in just a sec. There's also education project grants, education research trading grants from SAM. And then the EM Foundation also does have some education funding as well. The Eileen Harris Legacy Research Fund from Chicago is in association with their master's program, the MHPE. It's kind of a related thing for this, but they do also have, I think, about 40,000 a year for MedEd research. They do not specify that it needs to be domestic. From conversations I've had with them, they would be potentially interested, but it's probably worth an email before you go through the time to submit a letter of intent. For additional training in MedEd, I mentioned the ARM MedEd program. This is through SAEN, and it's a one-year program. It starts at SAM conference and the annual meeting and ends at the annual meeting, but you apply in the fall. And it's really for earlier mid-career academicians. So I was in the cohort with some fellows and then with some people that were kind of more mid-career. There is grant funding after completing the program. So the design of the ARM MedEd is really in how to write a grant for MedEd. So it focuses on a lot of these kind of topics and kind of like a lot of the lingo in order to get a successful grant submission for this. You can also do like a true master's in MedEd if you're kind of a little more of a glutton for punishment to do this like after fellowship. A lot of them are online. So if it is something where you can get funding from your institution, that is something you consider. And then there's a lot of institutional MedEd programs that, for instance, the one at Stanford, forget the acronym for it because they keep changing it, but it's essentially like another year-long course where it's mostly online, like Zoom sessions on, and they talk about the different areas in MedEd and you can get some more feedback. So if you have a project idea that's kicking around, but you're not really sure how to make it truly MedEd research, like how to get like the lingo and get the phrasing and get the design that you want to make it like a truly robust program, that could be, and you don't have a big MedEd group within your department, that could be an option where you look for things like outside the department, but within the institution, this as well. These are kind of like some of the big starter books. The reason I linked these two articles is that they're actually from the ALIEM academic primer series. And so they're listing of multiple different papers, but they give you a info little section on each paper. So you can figure out which papers you want to start with. So if you're looking for education theory stuff, you can start with that. If you're looking for more study design, you can start with that. All right. I have now been talking for about an hour. So I am at the point for questions. Any questions, comments? It's one of the papers that's listed as that key theory, the academic primer things for Colin's comment. One of the papers about it has a lot, I think it's like the author is Bordage, I want to say, but it talks about conceptual frameworks with very concrete examples of using the conceptual frameworks that I found really helpful for kind of making it a little less scary. I think a lot of the lingo for this is very intimidating in a way that it really doesn't need to be, but it's the way the system is set up for it. So I don't really have another option. This is something where if you're wanting to publish in the MedEd space, then you kind of need to include that.
What I found is something called conceptual frameworks to illuminate and magnify. Does that sound familiar?
I think that's familiar. I think I actually might have it open still. Let me see.
I also found a non-firewalled version, so I'll post that one in the chat too.
Yeah, this is it. The one that you posted, Adeline, is the right one. That is the one that I was talking about. And this one, what I liked about it is because it includes all these examples for it. The two articles that I listed, basically, one of them includes that, but they also include like other ones that are in like different, kind of just different descriptions. So it's something where if you're trying to figure out how to describe something, or you're trying to plan something and you want to kind of go into it the kind of ideal way and get everything like set up in your head beforehand, looking at those kind of descriptive articles can be really helpful. And it's a lot of it is just more learning the buzzwords. And it doesn't have to be like identifying the cognitive theory, like learning theory kind of thing. It can be things as simple as like learner centered, Patrick levels, like that kind of stuff can be very basic.